The next thing I think that's going to happen in the future is, here's a famous photo from Professor Steve O'Reilly and Sir Faruqi in Cambridge of one of the first patients that were diagnosed with leptin deficiency. Now, just to remind you, leptin deficiency is incredibly rare. I still think there's less than 10 people in the world that's been diagnosed with leptin deficiency. But here you have the young child on the left, and this child was just hungry all the time. Okay? Because this child's adipocytes did not make the hormone leptin. And therefore, this child's subcortical areas of the brain thought that it was starving all the time. It did not have enough adipocytes, and therefore, the child was hungry and eating all the time. Now, when they discovered that, they treated the child, and it's the same child on the right-hand side. Okay? Now, I'm going to ask you to raise your hand. Who of you think that the child on the right-hand side has obesity? Raise your hands if you think the child on the right-hand side has obesity. Raise your hand. Okay? It's a couple of hands. Okay? Fine. Right? Put your hand down. Now I'm going to give you another option. The child on the left-hand side has a blood pressure of 200 over 120. Okay? I treat that child with effective pharmacotherapy, and the child on the right-hand side now has 3 agents that they're taking, but the child's blood pressure now is 120 over 80. Okay? Who thinks that the child on the right-hand side with a blood pressure of 120 over 80 with 3 medications, who think that child has hypertension? Raise your hand. Right, okay? That is what I think is going to change in the future, right? So what the child on the left has is obesity. What the child on the right has is well-treated obesity, right? So our effective treatments, be it surgery, pharmacotherapies, or nutritional therapies, will not be able to cure obesity. The only thing we can do, the best I think we can hope for, is that we will have well-treated obesity. So if you ever see somebody saying these new treatments are going to reduce obesity, no, it won't. Okay? It will reduce people's body mass indexes, it will reduce the complications of obesity, but people with these treatments will have to take it for the rest of their lives. You take a nutritional therapy, you have to do it for the rest of your life, or pharmacotherapy, or surgical therapy. Because the minute you stop the treatment, the disease will relapse. If I stop the leptin on the child on the right, the child is going to revert to a phenotype as shown on the left. Because leptin therapy doesn't cure the obesity, it treats the obesity. And of course, we've heard today already about new treatments such as liraglutide and semaglutide, but I want to show you the next the next thing that I think is going to change in the future, and that, Alex has alluded to it. At the moment, if you ask anybody, they will say, if you want to run an obesity service, you have to have a very good multidisciplinary team, okay? Because that is the best thinking of the time. But what do I think is going to happen in future? Okay? And I say this to you because I trained as a lipidologist in one of the best hospitals for lipid treatment in the world, the Hammersmith. And we had big multidisciplinary teams. We had LDL apheresis. We did terminal ileum bypasses, as was shown in the randomized controlled trial in the POSH study for people with familial hypercholesterolemia. And then we got statins. And we completely changed the way we practiced, right? So if we now think about obesity, let's look at the step 1 study that was shown. And this is 16% weight loss with semaglutide 2.4 milligrams, with a 500-calorie diet, 150 minutes of exercise. So any good general practitioner can give this to the patient. Here is the step 3 study, intensive behavior therapy. Psychological visits, dietetic visits every 2 weeks, seeing an exercise physiologist with semaglutide 2.4 milligrams, 16% weight loss. Okay? Here is the step teen study. Now we're treating 12-year-olds to 18-year-olds. Right? And most of you that have children or have grandchildren will know that a 12 to 18-year-old almost never listens to what you say and hardly ever does what you say. And we know that because if you look at the placebo arm, they're the only ones that didn't lose weight. Let's just go back. Do you see how effective step 3 was? The placebo arm, intensive lifestyle therapy, gave almost 7 or 8% weight loss. Here is the step 1 placebo arm. Adults, they get about 2 to 3% weight loss. Now look at the placebo arm for step teens, 0% weight loss. Okay? Because they are adolescents. That's what they're supposed to do. They're hardwired for that. Okay? But now look at the weight loss in the semaglutide arm, 16% weight loss. Okay? So if you treat adults and you tell them to eat less and move more, they lose 16% weight. If you treat adults and you give them incredibly intensive treatment, 16% weight loss. If you treat children that don't listen to anybody, 16% weight loss. Right? So I work in one of the best centers, obesity centers in the world. We have some of the best treatment options at the moment. But I'm pretty confident that if the man on the dark side of the moon prescribes semaglutide 2.4 milligrams, they're going to have exactly the same amount of weight loss than I do. Okay? Because there's nothing that I do that actually makes these people lose weight. It is the drug. Right? And therefore, if we can teach people, as Alex has said, in the periphery, to treat people with obesity with these effective treatments, if we can show them how to do it safely and effectively, we are going to do a massive service to our communities. And remember, again, I'll remind you that certainly in Europe, we have dramatically reduced the number of heart attacks that people get and the number of deaths from cardiovascular disease. And it's not because we are prescribing statins in hospitals that has happened. The reason why we've reduced mortality from cardiovascular events in Europe is because general practitioners are prescribing statins and ACE inhibitors really effectively. And some of you in the audience may remember when we had the captopril test. Captopril, you had to bring people into hospital to give them an ACE inhibitor to make sure that their kidneys don't shut down. Right? Today, general practitioners are prescribing ACE inhibitors and it's really effectively treating it. So yes, it's a process. Yes, we have to start obesity treatments in specialist centers, but the quicker we can move it into the periphery, the quicker we're going to have a benefit. You've already seen the slide where I'm suggesting to you, in the future, we will no longer think overeating causes obesity, but we will understand that the disease of obesity causes people to overeat. That sounds a little bit crazy if I say that to you right now, and I appreciate that sounds a bit crazy, okay? But let me try to say something to you a little bit closer to home. Do you think eating sugar causes diabetes, right? But you understand that if you have diabetes, type 2 diabetes or type 1 diabetes, you will have increased plasma sugar, right? And that is the same concept. That's the same concept as understanding that the disease of obesity causes you to overeat, than it is to understand that the disease of diabetes causes increased plasma sugar. So we've seen the tirzepatide data. I'm just going to remind you, 22% weight loss. We had a fantastic lecture, showing the tirzepatide data in people with diabetes. Here I'm showing you the people without type 2 diabetes. And this is revolutionary, where we have a third of people losing 25% of their body weight. Okay? Now that is what you remember, and that's what you should remember. But now, you're going to start treating people with tirzepatide. And it turns out you're going to have exactly the same responses than anybody else in the world with these treatments. And here I'm showing you the individual responses to tirzepatide, right? And what I'm showing you on the top hand is, first of all, the placebo arm. And you can see that 70% of people in the tirzepatide arm, in the tirzepatide studies with placebo lost weight, but you will also see that a third of people gained weight while they were having lifestyle treatment, in this study. Now look at the tirzepatide arm. Here you see that 97% of people lost weight. And if you go all the way to the right-hand side, the last blue line, there was a person in the tirzepatide study that lost 50% of their body weight. They lost half of their body weight. That means if they had a BMI of 40, we took them down to a BMI of 20. Okay? So for the first time ever in these studies, we are thinking we have to have rescue therapies for if we make people go too low. Okay? But it shouldn't be a challenge because this is just another hormone. So again, I think at the moment people are saying you must use the regulated doses. Everybody must have 10 milligrams or 15 milligrams of tirzepatide. Okay? But if I say to you, I give you insulin, okay, but you are only allowed to use the maximum dose of insulin that you can get out of that pen every time. You will say to me, you're completely crazy, because everybody is going to have hypos all the time, right? So it's just a hormone. Insulin is just a hormone. GLP-1, GIP are just hormones. We do not have to use the highest dose. You use the dose that is effective to your patient. So I think that's going to be a big change. But another change that I also want you to think about in the future, right now, we are all thinking 22% weight loss on average. That is amazing. But that's the median weight loss, right? It's also the mean weight loss for that matter because it's a Gaussian distribution. But remember the edges of that distribution. You will see here on the bottom there were about 3% of people, 2.5% of people on tirzepatide taking the drug at 15 milligrams who gained weight. Okay? So do not be shocked if you have people that you treat with tirzepatide or semaglutide 2.4 milligrams that don't lose weight. Because there are certain types of diseases that will happen. But please promise me when you do that, and I'm pleading to you right now, please do not blame the patient. Because if you want to experience the most extreme forms of stigmatization, you should go to a bariatric surgery clinic where somebody had a very good sleeve gastrectomy or gastric bypass and did not lose weight. Those patients are told, you must be an incredibly bad person. I have done a very good operation, and look at how bad a person you are. You don't even respond to the best treatment. And that is what's going to happen when we start treating people with these drugs. If you say to somebody, and they come back and they say, no, the drug's not working, the first thing you're going to ask them, and it's a reasonable question, are you taking it right? And even people who take the drug in exactly the right way, there will be some of them that don't respond. I completely accept and agree. There will be some people that will just not be compliant. Compliance is different to response. Okay? We have to work those two things out because that will be very important. So what we will understand, and I'm showing you this graph because this is another thing that I think is going to be very important for the future. These drugs are now being sold to you and explained to you as these drugs change appetite. These drugs change hunger and change satiety. And that is very true, and it's incredibly valuable because when you start the treatment while patients are losing weight, this is exactly what they report. And here's another Greek character that actually, he was so hungry that he had to sell his daughter to get money to buy food. Okay? And it just shows you, if you're hungry all the time, what you are driven to, it is an incredibly bad thing. So when you start treating people with these medications, they will come back to you and say, "Doctor, this is the best thing you've ever done. I'm just not thinking about food all the time. I'm not driven to food, and it is wonderful." Okay? But then, 1 year after you've treated the patient is going to come back to you and going to say to you, "Doctor, the treatment is not working anymore because now I feel hungry, now I'm eating more food, and I know this drug isn't working." And you will say to yourself, "Well, this is a really expensive drug. This patient has lost 22% of their body weight, so obviously it worked, but the patient tells me, they're feeling hungry. And the company told me this is a drug that reduced hunger." Okay? So clearly the drug is not working anymore. Okay? Now I will urge you at that point, do not stop the drug, because if you continue the drug, what will happen is the patient will become more hungry. The patient will eat more food, but the patient will not gain weight. Because what has happened is the patient has come into a new state of homeostasis. The patient was in homeostasis before treatment. The patient will come to new homeostasis, and while they are coming down, they feel less hungry, they feel more full, they eat less food. But once they reach the new state of homeostasis, they will just become normal again. However, if you stop the drug, the patient will become hyperphagic. The patient will become obsessed with food and will regain weight rapidly. And we are seeing that after we stop all the drugs in the drug trials now. The patients come back and they are beside themselves from hunger. Right? And it almost borders, a lot of people are now saying, is it ethical for us to stop the treatments after? Because the patients become anxious, they develop severe mental health impairment because they are so ravenous. They feel like that gentleman, that Greek character who sold his daughter because they are that hungry when you stop the drug. The final thing I think that I will say what the future will hold is that when you lose a third of your body weight or 25% of your body weight, it is true that you will lose predominantly fat mass. And that has massive benefits metabolically, it has massive benefits also mechanically. But if you lose that much weight, you are also going to lose muscle mass. And I don't think we are paying enough attention at the moment to the muscle mass that people will lose and how we will prevent that from happening. Now, let me be clear. I don't think it is a game changer. I don't think it is the reason why we should not treat people. But it's something that we need to work out very quickly in the future, because we're going to take people, we're going to make them lose weight, and patients are going to come to us and they're going to say, "I just don't feel as strong as I used to be." Okay? And therefore, we need to be able to address that and think about that. Now, the muscle mass that people are losing is not as much as we thought it would be, because people come to homeostasis, but it is still substantial enough for patients to be concerned about it. So those are the websites again for Sophia, because I think Sophia is going to be part of changing this. So I'm going to summarize and suggest to you. Up to this point, most of us genuinely thought that obesity was an energy balance problem. It means that we thought the problem with obesity was that there was too much energy in and not enough energy out. Okay? So let me suggest to you, this is my house in Northern Europe. Okay? And what you will see at the bottom on the left-hand side is my boiler that generates energy into the system. And the windows in my house is pretty good because it's very well insulated, so it reduces the energy out. And my house typically is running at about 21 degrees Celsius. So that's the temperature inside my house. Right? Now, when my children run around and they leave the door open or they leave a window open, my house loses a lot of energy. There's a lot of energy that suddenly goes outside of my house. But the temperature inside my house does not change. And the reason why it does not change is because the boiler starts working and it pumps energy into the system. So even when the windows are open, the house temperature remains the same because the boiler is so good, it's just keeping the energy the same. It's keeping the temperature the same. So the temperature in my house is not controlled by the boiler, and it's not controlled by the windows. The temperature in my house is not controlled by energy in, energy out. The temperature in my house is controlled by the thermostat that I change inside my house. And sometimes my wife wants to make their house 25 Celsius, and she turns up the thermostat, right? And then the house is 25 Celsius. And then when I come in, I turn the temperature down to 20 Celsius. Now what happens is the minute I turn it down, the boiler stops working. The boiler is not pushing energy into the system anymore. But it only does that until the house comes to 20 Celsius. When it comes to the new state of homeostasis, then the boiler kicks in again and starts working. Okay? So that is what's going to happen to patients. Their obesity is not controlled by energy in or energy out. Their obesity is controlled, we think, by the thermostat effectively that sits in the subcortical areas of the brain that controls the amount of adipocytes the body wants to carry. And if you treat the person with obesity with tirzepatide or semaglutide or an operation, and they have a BMI of 40, and they come down to a BMI of 28, what will happen is on the way down, the boiler won't work, so they won't have energy in, they will eat less. The minute they come to their new set point at a BMI of 28, the boiler is going to start working again. Okay? They're going to eat, they're going to actually stay in the new level of homeostasis. Okay. So I think this is going to be something for the future where we understand obesity not as an energy in, energy out problem, but we stand obesity as a fundamental pathophysiological process that is deranged. And what we will be able to do is treat the pathophysiology of obesity. And the way we will treat it is with nutritional therapies, with pharmacotherapies, and with surgical therapies. And the way we know it will work is when people come back to us and they say they have a reduction in appetitive behavior. And as I said, while they are coming down to their new set point, they will have less hunger and more satiety, but that will stabilize when they come to it. So I'm going to conclude and suggest that we will only be successful in the future, and I think this is what the future will do, because we are always more successful in the future. So it just depends on how quickly we get there. But what we will get to is a point where we will treat obesity as we treat any other disease, right? And I am going to show a hierarchy because we need to have a structure of thinking. Okay? So, I think we do need more self-directed lifestyle changes. But people that don't respond to that, they need to be referred to, for example, professionally directed lifestyle changes. If they don't respond to that, they need to be considered for anti-obesity therapies. If they don't respond to that, and we know if they don't respond within 3 months, they need to be considered for surgery. And if they don't respond for surgery, they need to be considered for combination therapies. Where I completely agree with both Alex and Iba that made the point is today I don't have a blood test or a questionnaire that can tell me this patient must have a medication, or this patient must have a nutritional therapy, or this person is not going to respond to bariatric surgery. And there's some pretty good data in Nature Medicine earlier this year that shows whether or not I decide as a doctor or whether the patient decides where they enter that system makes no difference. Okay? So if a patient comes to me with a body mass index of 41 and the patient says to me, I would really like a nutritional therapy, I am not going to say to that patient, no, you must have an operation. I'm going to say to that patient, listen, we have nutritional therapies, pharmacotherapies, and surgical therapies. If you want to start with the nutritional therapy, that's a good place to start. It's as good as anywhere. But if you don't respond, we need to change. If that same patient comes, 2 days later and say, doctor, I read a little bit more. Actually, now I would like to have an operation, right? The patient is eligible for an operation, and there's nothing that would suggest that I must force the patient to have a nutritional therapy or a pharmacotherapy first. So that is why we are trained as clinicians. We need to have a framework. We need to understand that we actually have an ability to go through a normal treatment regimen, but we also need to understand that we need to personalize our treatments. And unfortunately today, we don't have a biomarker that tells me, listen, you will really respond to treatment X, or really you should never have treatment Y because you will have complications. We're not there yet. So I would like us to be humble and say, look, we don't have that information. Let's work with our patients and actually don't block people from having treatments, but make sure that if they don't respond to a treatment, that you are able to escalate them. So in conclusion, I will say the future of obesity care will include that we are thinking of this as a chronic treatment aimed at health gain, not weight loss. Okay? When I treat somebody with a statin, I don't treat them to reduce their cholesterol. I treat them to reduce their macrovascular complications. If I treat somebody with an ACE inhibitor, I don't treat them for their blood pressure. I treat them because I want to reduce the complications of hypertension. Okay? The treatments for obesity is not there for weight loss, they are there for health gain. Secondly, I think we will be recognizing the different subtypes of the disease. We are not there at the moment. I have no ability to make that diagnosis, but we will have that ability in the future. We will have predictors of risks and predictors of response. And that is, right now, we have incredible treatments. We don't, but in the future, we will want more weight loss with fewer side effects. And we don't want people that don't respond. And that is going to be possible. We'll need, it will include needing more and different treatments for the subtypes. So I think we will need more nutritional therapies. We will need more pharmacotherapies. And I think we'll need more surgical therapies. A lot of people are saying now pharmaceutical companies should stop inventing new treatments for obesity because we now have tirzepatide and we don't need anything more. That would be a little bit like saying to somebody, we had simvastatin in 2002 and we should stop inventing. We would never have had PCSK9 inhibitors. We would never have had rosuvastatin. So no, I think we need more innovation and we need more different medications and nutritional therapies and surgery. And ultimately, I think the future of obesity care will include not blaming our patients for their disease or if they don't respond. So thank you very much for this opportunity and thank you for all the kindness.